On Bay Area Psychology, we take a close look at managed care, an increasingly visible reality for employees throughout the country. I feel led to start with a joke that in many ways reflects the emotional response to managed care that prompted tonight's discussion. 3 doctors die and go to heaven. At the pearly gates, St. Peter asks them why they deserve to be in heaven. The first doctor says, "I was a surgeon and I saved many lives." And St. Peter says, "Well, that's good. Come on in." And the second doctor says, "I was a pediatrician and helped many children get well." And St. Peter again says, "Well, that's very good. Come on in." The third doctor says, "I managed medical benefits and saved money for a lot of businesses who employed a lot of people." And St. Peter says, "This is good, and you have been pre-authorized for 5 days. I'll see you again on Friday for discharge." If you hear the sharpness to this joke, you may be one of the many people who are frustrated by their PPO, HMO, or medical plan. How did a system that was originally designed to contain healthcare cost excesses and abuses become so confusing and frustrated? Tonight on Bay Area Psychology, we have a different format, and I'm going to talk with you a little bit about managed care. We will hear from a couple of different people throughout the show about their experience of managed care and what that has been like for them, both positive and negative. What I thought I'd do is tell you a little bit of history, at least from my experience of managed care, working in both the mental health and chemical dependency communities. In this particular county, which is Santa Clara County, around 1991 or so, I began to see a shift in the way we began to deliver care services at the hospital. At that point, I was working at El Camino Hospital, and one of the things that became most apparent is we were beginning to have to, as caregivers, become responsible to the insurance companies themselves. They began to assign case managers, and as case managers, they would call us as treating counselors and ask why we were delivering the services we were delivering, and could these services be provided in a shorter amount of time for less amount of money. Now, this shift came in response to healthcare benefits and abuses and excesses and the rampant and rising costs of medical health care. And part of the solution was for companies to hire intermediaries called managed care companies, to begin to manage the benefits of these employees, to be able to do cost containment. So the idea was, instead of charging $895 for an aspirin, that perhaps we would be able to deliver services in a more efficient and effective way. That in fact, not everybody needs to go to the hospital for inpatient care. Not everybody needs to stay for 6 or 7 days for something that could also be done outpatient. So we began to get more clear about who needed what kind of services. Let me show you a graphic with the definition of managed care that might help this be more plain. Managed care consists of an identified intermediary agency between the insurance company and the employer that manages the medical and psychiatric benefits held by the employee to provide the most amount of treatment for the least amount of dollars. Now, one of the things that can happen with this particular emphasis is a complaint sometimes that in the effort to contain rampant cost, we have sometimes sacrificed quality of care. Let's hear from a moment from someone who had a recent experience with his managed care company.
I think managed care gives the caregiver the incentive to milk the system. He can give less service and still get full fee for his office visits and for his other care. An example is my wife. Just this week went in to see the doctor. She had symptoms which related to her heart. The caregiver didn't even take her blood pressure. He collects the $35 fee. We paid the $6 that we owe, and the cost of Medicare goes up.
So why does this happen? How can this happen? We have doctors who are well-trained, who enjoy delivering fabulous service to clients, doing things like not even taking a blood pressure. Well, part of this has to do with what's called often a capitated healthcare system, which means that Aetna, for example, employs a managed care firm like, let's say, U.S. Behavioral Health to manage the dollars. And so they have a certain amount of dollars per person, which is called per lives, covered by this program. Now, what the managed care company then does is contract with providers, particular hospitals, particular physicians, and say, we will give you a sum of money per year. And for this sum of money, you need to treat all of these lives. And so if you're able to treat these clients or these patients as quickly and efficiently as possible, what that means is that the managed care company gets to save money. See, the managed care company gets to keep whatever money it doesn't spend in treatment. Okay? So what happens is that doctors who want referrals agree to this sort of capitated plan, and then they need to provide services, which means that doctors have the risk. If they provide too many services to you and they use up all the money that was originally in the capitated plan, then the doctors are providing services to you at a financial loss to themselves instead of the insurance company. I hope that makes sense. Let's take a look at how we can access our benefits. We have different plan types. For example, at an HMO, you might need to call your primary care physician to access your coverage. You might need to call a specific medical group, or perhaps there's a case manager assigned to your particular company. So you'll call an 800 number and speak with a case manager. A PPO might be, again, an on-site manager that might go ahead and screen you and decide that, in fact, you do need treatment. There might be an external review company, which is, again, maybe an 800 number with a company contracted, even in another state, to screen you and decide whether or not to refer you for treatment. And this would often include a telephone review. And finally, there's an EAP, which is an employee assistance program, where you might be screened by a licensed professional. This is often employer-sponsored or health plan-sponsored. So it isn't, with a managed care company, you can't just walk in and say, I would like to have a physical. What you need to do, or I would like to see a psychiatrist. You would see somebody, an intermediary, often what's called your primary physician, who would talk with you about that and then decide if you're warranted to see a specialist or you're warranted to go on and then speak to a psychiatrist if the doctor feels you have the symptoms that might be appropriate. Now, we determine these symptoms based on what's called medical severity, or we basically look at medical necessity. And what that means is your symptoms have to fall into a certain amount of severity to qualify, okay? Because managed care companies, when you have this pool of money, don't pay for what we used to think of or do think of as sort of wellness treatment. For example, psychotherapy. If you would like to see a psychiatrist or you'd like to see a psychologist, you would have to have significant symptoms depending on your plan. For example, your plan may only cover things like clinical depression. So you would need to be having difficulty sleeping, difficulty concentrating, feeling suicidal, for example, or anxiety to the level where you can't sleep at night, or you're breaking out in perspiration, or you're having heart difficulty. So, in other words, in a perverse sort of way, the worse you are with your symptoms, the more likely you are to get treatment. Which does pose a problem for treating physicians, doesn't it? Because if you're referred to your therapist is in the bind of having to ask for continued visits. Because just because a primary care physician says, okay, I'll refer you to counseling, often your managed care plan will say you're only entitled, for example, to 20 visits. But we don't give you 20 visits at a time. What we do is we may approve 3 visits. And if your therapist thinks you need more visits, your therapist has to request, by filling out some forms, continuing visits. So often you have to ask for them 3 and 5 visits at a time. So just because your insurance papers say you are entitled to 20, that's not true if you don't meet medical necessity. So therefore, your psychologist or your therapist will have to give you a clinical diagnosis, okay? And the diagnosis may often be a fairly severe diagnosis for you to meet those medical necessity requirements. You may wind up being diagnosed with clinical depression or an anxiety or an adjustment disorder, something fairly significant in order to justify your treatment plan paying for those visits. One of the ways I, for example, handle that is when I see managed care clients, and I often do, I explain to them that to access their visits, we will have to find a diagnosis that will qualify. Now, the diagnosis needs to match their symptoms, so it's sort of a catch-22, which is if they're not disturbed enough, then chances are I won't be able to get more visits. And if they're getting better, I may not be able to get more visits, because the better you get, the less, of course, you meet medical necessity. So therefore, you see the craziness of this system and why people will say, well, my therapy's working, shouldn't I keep going? Where your insurance company might say, well, your therapies work so well, I don't see why you need to keep going. So it is kind of an insane thing where often people will wind up relapsing with their symptoms, and then, of course, they meet medical necessity again, and they can then request more visits. So if your doctor or therapist doesn't take managed care, that's probably why. We're going to take a quick break, and when we come back, we'll talk further. We'll learn about the values of a managed care system. Stay with us. Welcome back. Well,